So I'm going to talk a little bit about physical examination of patients with children with the gynae presentations. Before we start talking about when to look down there, let's talk about when to look in there. So when do you need to do the examination in a prepubescent child's internal examination? Obviously, for us, gynae examination on a child, it seems to be something of a big taboo, something what we don't do, something what we shouldn't do in the ED. As just Dr. Annika, I've seen the response on the chat. Any gynae examination we should be doing with the chaperone and with the consent. We usually don't have time. We are not familiar with it, so we don't do it. It's sort of hell in our minds if we need to go there. One of the plots of my talk today will be why we really shouldn't do the examination, why we should avoid it. The problem is that in children there's a lack of estrogens, and the fact that the vaginal and vulvar mucosa is very thin, very sensitive, and very friable. So every examination which we perform is very uncomfortable for them. So because of that reason, we should avoid it as much as possible. Especially the internal examination I am talking about now. So my answer to the internal examination will be almost never, and almost never because you need a very good reason to do that. You are going to need anesthesia, and you will probably have to inform the consultant anyway. So it's better to hand over the case to the consultant directly, and it's either pediatric or gynecology if that's required. But on the other hand, we will be doing the examination of external genitalia, external examination. I can link to the Adil's presentation when that would be actually very helpful in that case. We need to put a child initially into the position which is helping us to actually perform the examination properly. And one of these positions is the cubital position, which you can see on the right. That's the one which gives us the best visualization. But not everybody is comfortable with that position, especially small child. So what I usually do, I ask the mother, mom or dad, to put child on their lap, symptomatic. Then we don't really have to do anything unless child's family would like us to do something. Generally, they will grow out of it on their own. Sometimes we need to prescribe estrogen cream to be applied twice a day for 4 weeks, 4 to 6 weeks. If that doesn't help, we can repeat the course, and we do it until the membrane dissolves. We can watch them, follow up even with the GP, and once the membrane dissolves, then we can stop the treatment. Obviously, if they are completely obstructed, then it's a surgical emergency. But one thing not to do, and I really want to emphasize it, is not to manually separate the labia yourself because of the pain, because they are going to, as bad as it sounds, stick back together anyway. So we absolutely shouldn't do that. Yes, so as I said, 80% resolve spontaneously within 1 year. We can use emollient cream as well, just for the stinging, for the unpleasant feeling, just to make them comfortable. Topical estrogen cream. We can repeat the treatment, and complete obstruction is the emergent surgery. And what is that? That is when we can see like a friable donut around the urethral area, purple tissue right around the urethra. That's the urethral prolapse, and that's mainly in the estrogenized, as we said, that children have little estrogen levels. Kids who suffer from constipation, from raised intra-abdominal pressure. That causes the urethral prolapse. Usually it's asymptomatic as well, but it may cause, similarly to labial fusion, dysuria, pain, even bleeding, frequent UTIs, and obstruction. And if you see that, you absolutely need to treat the constipation if the child is constipated. If they're asymptomatic, you don't really need to do more than that. Just give them Movicol for constipation, and that should help on its own. Obviously, if you would like to treat it with something else, you can give estrogen cream for symptoms relief, purely for symptoms relief, and pseudocream, some emollient as well, to help them pass urine as that becomes uncomfortable, or sits baths once in a while. Yeah, and if the treatment fails and children are symptomatic, or if there's a complete obstruction, then again, we need to ask our surgical colleagues to help and operate the child. It's again, surgical emergency. The next presentation I would like to talk about, which is more common, is the vulvovaginitis. It's usually, vaginal area is usually okay. It should really be called vulvitis because mostly vulvar area is inflamed, but they are very symptomatic. These children are very symptomatic. They come scratching, itching, school might complain, often have some discharge from vaginal discharge, maybe a little bit of blood even. Parents are very worried. This is usually due to irritation of the friable tissue, which is the vulvovaginal area, which is very sensitive. And children, what we use for the baths, we use soaps, bubble bath, scented baths, foaming soaps. They can mechanically irritate the area, the skin, and that can cause mechanical inflammation. Treatment is easy. In this case, just what we need to do is just take away the irritants, if that's what's causing the problem, and use some emollient, again, a pseudocream or any other Vaseline over the area, and that should release the symptoms. Unless it's a very angry area, very symptomatic, then we can use briefly steroids for about no more than 2 weeks. Okay, I talked about this. A foreign body, which is, in this case, is just a catheter. But I wanted to put some picture with the foreign body in the vagina. Which is placed very superficially, and it's very easy to remove in the vagina. So, but it might come, actually, they might present with a chronic foul-smelling discharge, blood tinge. In those situations, what we should do, we shouldn't still do the internal examination. We should avoid that. We can use the warm water and do some irrigation, like we irrigate the ears, and that should be enough. If it's a stuck toilet paper, for example, or a piece of tissue, that irrigation should be enough for the paper to actually come out, to disattach from the walls of the vagina and come out and be removed. Obviously, the deeply inserted objects we won't be able to identify, but that's a bigger problem then. There are safeguarding issues raising in those cases. Pediatricians need to be informed, maybe social services. So those cases we should hand over if it's something else. We can do the pelvic X-ray to see if there's anything obvious stuck there. Case of straddle injuries. Children, obviously, they can jump and inflict those injuries on themselves in different environments and land on different objects. Usually those injuries, there are small tears. They present with small tears in posterior area, in the fossa navicularis, which you can see at the back, or between the labia minora and labia majora. So that are the two main areas which can be torn. So if the child comes with a straddle injury, what we should think about, We should see if there is any hematoma. We should assess if they can pee or not. If they can, we need to make sure if there's no hematoma which is large, which is expanding, which can potentially cause the obstruction. So observe, or for a while, we can admit them even under pediatricians. If they go home, they will need some ice packs, advice, and PRN analgesia, and that should resolve on its own. If there's a small tear, on the other hand, which you can localize, and you have good hemostasis, there's no bleeding, then that's fine. You can child still can go home, but with no other intervention. But maybe we'll need some pseudocream again, just to release the symptoms, and analgesia if it doesn't need stitching. Obviously, there are situations where there's larger tear and external tear, which we can see. Perhaps it's a little bit deeper, what we can't really assess. Those children, they need to be examined by a gynecology team or pediatric team, usually, and if they need a couple of sutures or more, then they will need to have it done under anesthesia in theaters. So they need to be admitted. Straddle injuries, I always ask myself a question: how did they do it? What did they land on, if it's possible to identify? Is it like a little toy car on the left, which is flat on top and wouldn't cause deeper injury? Or is actually a Disney castle with sharp turrets, and they can go very deeply and cause internal injuries? So that's important, to try to extract this information from the parents or from the child, if possible. Or if they fall on a fence, I always ask if it was like a cemented wall, like the one on the left, or is it a fence with the spears, which is, again, potentially might cause deep internal injuries. And the last, which is very rare, it's called impalement injuries. So there are the straddle injuries, which go really, really deeply. And they're managed very differently. They obviously need to be taken to theater. Sometimes they might go, the injuries, through uterus, through the bladder, through the bowel. Whenever we have if there's a profuse bleeding, which we watch, if we can't achieve hemostasis, if child is in severe pain, then we really should be very vigilant, and we should think about the deeper injuries, especially when they bleed and they can't stop bleeding. Normally, these injuries, they should, if they're superficial, they stop. They stop bleeding pretty quickly. So those cases, we obviously need to refer to gynecology and to surgical team. Okay, so yes, thank you very much, and I hope we will be able to implement this external examination to our practice. And whenever we see abdominal pain, as Adil's case, we will look down there as well to make sure it's not a case. Thank you.
Thanks, Alicia. Annika's raised her hand. Can you speak, Annika?
Yeah.
Yeah.
Yep. Hi, thank you, Adil and Alicia. Thank you so much for your presentations. They were really interesting. I think there's a lot to learn from both of them. I just wanted to make a couple of points which are actually not very highly scientific, but I think in all the years that I've been doing pediatrics, there's a couple of things that have really stuck with me. I think the presentation of abdominal pain in children is actually a real minefield. And I think we underestimate how complex it can be. So I think obviously we get constipation, acute constipation, we can get chronic constipation, which is the most common thing. And sending them home with laxatives or sending them back to the GP actually just means they're going to come back to your shift at some point. So I think it's not the answer. And I do feel that if you're seeing a child with abdo pain in ED and it's not surgical, I would have a low threshold for referring to pediatrics. Because often you can't make the diagnosis in ED. It has to be something that needs to be explored longer term as well. And there's a whole range of things that it can be. apart from the acute things that you see in ED. So I think if you have a child that has recurrent abdominal pain, I would take it seriously and refer to pediatrics. Whether that's acutely or whether you do that via the GP back to pediatric outpatients. We have a lot of older children who have chronic abdominal pain, and they are so subject to lots of investigations, and that in itself can be quite traumatic. So I think, just to say to you, I would take abdominal pain, which is chronic or intermittent, seriously and think about referring. The second thing is, as a consultant and even as a trainee, I've never done a DRE on a child, and neither have I done a PV exam on a child. And it's just never indicated. And I think the reason I say that is, I know that Alicia pointed out the medical reasons for it, with the tissues being very friable and sensitive. Yeah, I agree with that medical reasoning. And I'm not sure if we have a gynecologist on our meeting today, but I think actually more than that is that we are not experts in examination of children, either with a DRE or with a PV exam. And we, even consultant pediatricians, will leave it to the experts in gynecology to do that. There are ethical issues around examination. I've never known a case where it's ever indicated to do a genital examination on a child. I'm very happy to do a visual inspection of the anal area and also of the external genitalia, but I would never do an internal exam. And I know we haven't talked about sexual abuse here, but I guess we do need to consider that in the context of this, these presentations. And the reason I was saying about not doing internal examinations is actually when you are suspecting child sexual abuse, the examinations are done by 2 pediatricians who have specific training in CSE. At that point, they need forensic sampling, etc. So that's a different kind of ball game. But actually, if you're going to ever do an examination in a child, it should be done correctly first time by somebody who is expert in doing it. And we should never do a cursory examination of a child internally, ever, in ED. Even on general pediatrics, even with expert pediatricians, we tend not to do any internal examinations. You're probably better off scanning or thinking of an imaging modality for looking for a diagnosis. And then I think just to reiterate that, I did say in the chat, but I want to also say that any visual inspection that is done in a child and a teenager must be done with consent. Now, I know there's consent issues as well. Under 16, we should get the parental consent, although there is, as you all are aware, of Fraser competence. So if a child is deemed to be mature enough and developmentally appropriate, they can consent to treatment themselves. However, please do ensure that there is documented consent, and it can be verbal consent, but it needs to be documented, and always please have a chaperone. The chaperone should have their name documented as well, so that the medical team is protected. There is lots of litigation around this, and it's becoming more. So please be careful when you examine a child, which is from waist down, that you do it appropriately. Younger children, it's probably okay. Toddlers, I think parents are more accepting. As the child gets older, please be mindful that it's a really difficult, it can become a very sticky situation for you in, going forward. So please do protect yourselves from that point of view. And I think the other questions that were asked about the incidence of hematocolpos, I think we've seen, I'm at Luton at the moment, we've seen one case in the past year. It's actually a rare diagnosis to make. But certainly I agree that when a child is 12 and over, 11 and over, with the possibility of having menstrual cycles, that menstrual history must be taken. And pediatricians are actually, I've got to put my hands up and say, pediatricians are bad at taking sexual histories and menstrual histories. It's not something we automatically think of in our differential, but I think we should do as a holistic approach. So I think it's really important. And just going on, one more point I wanted to make was about a child with any child that is old enough, usually 11, 12 plus, should have a heads assessment as well. Because whilst all these things, there are medical reasons, remember also that these may be sexually active children at quite a young age. So that history needs to be taken. And also, and I think Alicia did mention it about safeguarding. I think whenever you're looking at this kind of thing, straddle injuries actually automatically come into child protection until proven otherwise. And I think any straddle injury that you see, even if you as an ED doctor are convinced that it's nothing, it's always worth discussing with the paediatricians, because we will do the background checks about whether this child is known to social services, whether there's been any other issues in the background. And just one more thing I wanted to raise from that is the children that you see who are on a child protection plan and it flags up as a child, actually, for me, that child is already protected because they have a child protection plan, they're known to social services, known to the other teams. It's the children that are not yet known to multi-agency that are the concern. And I think we should be more vigilant given that we've been in lockdown, and you guys have all heard about the increasing incidence of domestic violence and child protection. We've had some horrible stories in the press recently as well. And I think we as frontline clinicians need to be very vigilant about what we are seeing and have a very low threshold. And I'm sure most of you do know that before the child reaches a child protection threshold, there's lots of work that goes on prior to that. And a lot of that is documented in information that we don't have in the hospital. So places like System 1, which is the place where the community teams document things, and social services, health visitor, etc. We often don't have access to that information. So we don't know the risks for the child actually when they present to ED. So I think the risk stratification in ED is more complex than is probably recognized. And so I think any injury down there, if you are thinking of doing an examination down there, you should involve pediatrics. And then I think obviously we will escalate to gynecology if we need to. But please have a low threshold. I think these need to be taken seriously.
Expected delivery that happens in the ED. For some unsure reasons, the most of the time that happens is early in the mornings or late in the nights. That's when these kinds of many patients that undergo delivery in the emergency department, we don't have any proper epidemiological data which I try to look for. So continuing with the case report, so the nurse goes saying that, okay, let me go bring this patient out. You quickly see the patient and send her home. So it's quite, sounds good. So all I hear from the nurse when she goes to see the patient is a shout out loud, which acted like a buzzer to be more precise. And that's when the Pandora box opened. We saw her kneeling on the floor with a huge pile of blood collected in between her legs. So we thought she had some kind of abortion. We thought we should move her to the appropriate places. And we thought it's a product that has come out. So at this point in time, there was quite a lot of things that was running in my mind, literally a million thoughts. The one was, who should I call? Should I push the buzzer at all? Is this even an emergency? If there is a newborn, what should I do with it? And where should this patient be? She was in the ambulatory major part of the department, and where should she be? And this girl present with the mother, if that's the case, how should we handle the mother and how to deal with the patient? So we moved this patient onto a trolley, tried to lift the product that was down, and it started to cry. That one, the shock happened for every one of us. And all we can hear was, there's a live baby on the way. Please give way. Let's move to resus right away. The few things that was standing out on the history was there was no clear obstetric history. We are not sure how long the pregnancy was. There's a full term, preterm, post-term, nothing at all. We have no idea what the comorbidities of the patient was, and how stable was the hemodynamics of the mother. We saw her bleeding, so we are not sure how stable she is and what's the resus status of the mother. Also, if it's a full newborn, whether it's a preterm or a full term, if it's a preterm, how should we manage it, which we didn't have any idea at that point in time. So we did call the most senior doctor and nurse in charge. We did fast bleed the obstetric team, and we did fast bleed the pediatric team. But we didn't push the buzzer at that point in time because we were literally brain frozen, and we tried to call the obstetric team quite a bit of time. They were stuck in an emergency. They were not able to come down to, and pediatric team took a while. So the first 15 to 20 minutes was just A&E to deal with this patient to see how it goes. So talking about different stages of labor, the stage 1 where you have the onset of uterine contraction, stage 2 is where you deliver the child, and stage 3 is where the placenta comes out. It need not be that the patient will be in just one stage of labor. They could be in any stage of labor, and that's the trick that always works. And also in comparing the presentations of the fetus, it could be in any type of presentation. You'd be lucky if it's in the normal position, that's the occiput left or right occipito anterior. So in delivering a child, just talking briefly about if this happens in our ED, how do we manage the situation? The step 1 is just guide the head down, just hold the head to allow slow delivery, allow controlled descent. And place one hand just on the perineum to prevent stretch on the perineum, and this significantly reduces the risk of tearing. And as ED, we try to do something a lot. So ideally, when the head comes out, do not try to pull it out, just let it slide out. And once the head slides out, guide it downwards for the anterior shoulder to come out, and then upwards for the posterior shoulder. Once the child is being delivered, the shoulder is the most impinging part. Once it comes out, then assess the baby if it's delivered, if it's all okay. Place the child on the mom's abdomen for the skin to skin tap. So what are we supposed to do post-delivery? Fine, I have a baby delivered. So few things that you could think about is you clamp it, you suck it, you dry it, wrap it, measure it, and send it. So you clamp the 3 centimeters from the fetal end, and then put a second clamp 3 centimeters apart on the umbilical cord. Just make sure there are no twins before you clamp the mother's end. And try to suck the child's mouth using a suction bulb to take all of the liquor if there is any. Dry to the clean warm towel and wrap it the clean warm towel. And 3 things that we basically need to measure are measure the Apgar score of the child, BM, and weight of the child, and send it to the most appropriate place, which would be the pediatric or the NICU if it's needed. Briefly talking about Apgar score, it stands for what it is. So it's appearance, pulse, grimace, activity, and respiration. And the highest score is 10. It's usually available on the app. And the time to do the Apgar score is you do it on the first minute, and the second Apgar score needs to be done on the 5th minute. If it's more than 7 and the child is actively sucking the mother's breast, that's all fine. If the Apgar score is less than 7, you keep repeating it every 5 minutes till 20 minutes duration to see how the child progresses. So talking about how did we do for in this patient, for an A department without much protocols on emergency deliveries in ED, we did pretty well. And yeah, as I said, the story with a happy ending. The most challenging part was handling the parents because they had no idea the child was pregnant. The mom was quite furious about what was happening. All we were able to do at that point in time was isolate the mom, give them a separate nurse or someone senior to take care of them because there are 2 lives at stake at the moment. So we all know in the emergencies, we have airway trolleys, which have your A, B, C, D of airways, and the surgical trolleys, which will have the perimortem sections and umbilical cans, and few other things which we might need when you be in the situation or resist here, and just a diaper. Looking at if we are well equipped. So this patient who delivered in the ED. So question is, when should we transfer to the delivery suite? And if different patients present at different point in time, when do you transfer them? And is it always possible to transfer them? Which is quite a tricky question. There should be an understanding between the obstetric team and the ED team to see when you can transfer the patient if they are on active labor. And if it's a bigger hospital where transferring them from one end of the hospital to the other end takes quite a long time, should you get them a quick ambulance and load them on? And how long does it take for the obstetric team or the midwife to come to the ED? So there should be crash call scenarios run to see how fast they can attend scenarios if these kinds happen. And what do you do in terms of management for the for the newborn as well as for the mother? And or do we have any existing guideline for those? And the most important is being the situational awareness. We don't want this child or the mom in the ambulatory images, move them to the appropriate place. Know where your steps are, the basic things, get your clamps and all those things. Right. Good, this child was above 16. So if we have someone below 16 and to treat them, do we have any guidelines at all? We did briefly hear about touching about the GLIC competence and the Fraser guidelines. enough intelligence, competence, and understanding to consent for treatment. If they consent for treatment, then you can treat them even without their parental consent. But there are few ifs and buts in the GELI competence. Say, for example, you should always encourage them to tell their parents about what's happening and what they are planning to do. And it could be overall if you feel that they are being pressurized or if they are being influenced. And if it's not valid, if the child could end up having a severe permanent harm, or if the illness could lead them to death. Talking about Fraser guideline, this is more towards contraception and the sexual health of the child, done in the best interest to receive advice and treatment. If the child is able to understand any advice given, and if they are still going to continue having sex with or without contraceptive treatment, and you cannot persuade them or talk them to inform their parents, and their physical and mental health are likely to suffer unless they get some advice or treatment. These are few things that we need to look for Fraser guidelines and should be applied if that's the case. So what are the lessons that we learned here? So as ED physicians, we are jack of all trades and masters of registration, isn't it? So re-evaluation is triage is primary. You do a news course, but this child was scoring quite low on news, but re-evaluation to see whether how she is and what should do should be appropriate. And appropriate escalate to seniors. If you have any concern, just write it straight away. If it's an emergency, push the buzzer. As ALS or ATLS, we run one scenario as part of regular life support courses, but there should be more to, because these are more stressful situations and we have 2 lives at stake. And we mean not many people of us are experienced in delivery in ED. So there could be a session or teaching about delivery in ED, how to do it and what all should be managed on. And if there is an obstetric crash call at all, and how long do they take to come to the ED? And do we have any management protocols set in place? And few basic things like a pair of umbilical scissors, suction bulb, the CTG would be a great value to the tool. These are my references for the presentation today, and thank you.
Thank you very much, Deepak. It's been a great presentation. Any questions?
Just wanted to say, I don't have a question. It was just to thank you so much. That was really useful. Actually, for newborns, it's newborn life support that we need, not APLS, which is very different.
Yeah.
So I think what I would really, and again, experience in ED, any baby that you think is going to be born, you should have a resuscitator ready. So I think ED physicians tend not to think of a resuscitator, but I think we do need to say, if you're having a delivery, I would get the resuscitator switched on and warmed up, because the baby's going to have to go onto resuscitator. That's how you're going to keep the baby warm. So as you will probably know, first few minutes is really crucial. The baby cries initially, that's fine. Just a couple of practical points. The 3 centimeters cutting the cord is okay. If you can leave it longer, that's even better. The more premature the baby, the longer the cord, because there may be attempts at central umbilical catheterization as a central line for fluids and drugs. So if you can leave a longer cord, it's much better, because obviously people will cut down if they can't get it. So try and leave slightly longer cord. There's also, at the moment, there's been new guidance from Newborn Life Support about delayed cord clamping as well. If it's a term delivery and the baby seems to be well and does not need an immediate resuscitation, you should delay the cord clamp for up to a minute. So please, so what I'm trying to say is that a newborn life support is very different to APLS. And if you have time, you're better off calling the neonatal team to come if you have one on site. I know at Bedford you guys have the pediatric team as well, but that's fine, they cover neonates as well. So NLS is quite different, and the main crux of keeping the baby safe is to put them on resuscitator, dry the baby, wrap the baby, because they lose heat through the head, and the temperature control of a baby. So with ED, you have ABCD, and with trauma, you have CABCD. But I think with neonates, it's TABCD, so temperature. Low temperature is linked to high risks of mortality. So with a baby, no matter whether it's term or preterm, it has to be temperature first. So wrap the baby, dry the baby, put it on the resuscitator. So if you are going to do skin to skin, that's great. The baby's well enough, and you can cut the cord after a minute while the baby's having skin to skin. If the baby is not making signs of life, then it must go on the resuscitator and be resuscitated properly with the neonatal team. So that was just to say that. Yeah.
Yeah, I would really
Thank you very much.
recommend the NLS course, because it's a one-day course for neonatal life support, and it's going to be such a rare situation that we need it in the ED, but I think it just gives you that reassurance. And the other thing I'd say is, and don't forget, if it's you're waiting for gynae and you're waiting for NICU peds teams to arrive in the ED, if you've got a paramedic around, often they're the ones who've delivered babies in the back of ambulances more often than we have in the ED. So always ask for help with the paramedics. They're quite useful to have around.
Mm-hmm. On this note, maybe I will mention the neonatal course, which is organized by Don't Forget the Bubbles on the 6th and the 7th of February.